If no other comments, I think we can move on to the last case.
Hello everyone, presenting a case of central Fuchs dystrophy in a 60-year-old female. The patient was suffering from too much glare for last 3 years. I gave the patient the choice of DMEK and DSO, that is Descemet stripping only. The patient chose the latter. So coming to the video of the case. Hello everyone, as you can see it's a case of central fuchs with peripheral cornea relatively being clear. So here I have planned DWEK, that is descemetorexis without endothelial keratoplasty. So marking the 4 mm central zone where I will be doing descemetorexis. It is always a good idea to mark your rexis clearly so as not to exceed the rexis size, because the rexis size is very important here. You have to keep it within the limits of 4 millimeters. A larger rexis is very has got a delayed healing or maybe no healing at all. So after making the side port incisions, I injected cohesive viscoelastic in the anterior chamber, washing the cornea so that I can see clearly the details where I have to initiate the rexis. So I've started the rexis using the reverse Sinskey hook. As you can see, I can get a leaf of Descemet or Descemet's membrane coming out, and using the ILM peeling forceps to initiate the rexis. The it's the ILM peeling forceps, sometimes it becomes hard to grab the leaf of the of so grabbing and again re-grabbing the leaf of the Descemet membrane, trying to complete the rexis from the side port only, but the some part cannot be completed. So I made a 2.2 mm clear corneal phaco incision, from where I introduced Sinskey hook into the anterior chamber and completed the rest of the rexes. Here I want to emphasize that the whole rexes should be a peeling movement rather than scraping kind of a thing. So inspecting the integrity of the flap that I've created, then flushing the viscoelastic out of the anterior chamber using the coaxial IA. Um, Hey, as you can see, the rexis margins can be clearly delineated in the red reflex. So I'll be starting the patient on routine post-op cataract regimen along with Ripasudil 4 times per day. That is going to go for around 2 months, um, and sealing the side port incisions now, and sealing the main incision and finishing up the case. So 1 month post-operatively, the vision was counting finger 1 feet with the presence of honeycomb corneal edema. Around 2 months, the vision improved to 6/12, the glare reduced. So my question to panelists are, what is your experience with DSO? Who is an ideal candidate for DSO? What is the role of Ripasudil? And what is the role of specular microscopy before taking up for surgery? Because some recent studies indicate that the peripheral endothelial cell count should be more than 1000 before taking up for DSO.
I'm just going to chime in real briefly here. That's a great presentation. I will say I have no experience with DSO. I don't perform that, so I'll turn it over to the other panelists. And I may need to excuse myself for another meeting in 9 minutes, so I'll turn it over to the others.
I also don't do DSO. So if there are any other panelists that are I mean, we all know that Fuchs candidates, Fuchs patients are the ones because you have the lots of the endothelial cells centrally, and you want to do a cell count peripherally. Pretty much all of them need to be on a ROCK inhibitor afterwards to clear. Otherwise, it takes too long. And then the failure rate's going to be, I don't know, up to 20%. And you would do a rescue DMEK or DSEK in that scenario. But honestly, that's my superficial view. So if anybody wants to chime in, some experts.
No, we don't do DSO as well. In a few cases that we have done, the results were not that encouraging, at least a couple of years back. But to answer your question about the role of specular microscopy, it is essential when you're choosing a patient for DSO, because you need to look at your peripheral endothelial count before you actually take in the patient. Because if you have a poor count, less than 1,000 cells, then that would not be an ideal candidate for DSO, and also works better in very early Fuchs dystrophy, especially in a patient like yours whose primary complaint is more of glare and related rather than an actual clinical decompensation of the cornea. But I don't have too much experience in DSO, so Aditya has his hand raised. I'll hand over to Aditya.
We also don't do it at our center, but I just wanted to know, Dr. Pratik, at the first month photograph, you showed there was honeycomb epitheliopathy, which is a known side effect of the ROCK inhibitor. So did you stop it at that stage or were you continuing it?
No, I let it continue.
Okay.
Yeah.
So it subsided on its own, the epitheliopathy?
Yeah, it subsided on its own.
Okay.
If I'll just chime in, the salient features from all the experts that do perform DSO versus my patient population are, inability to position adequately with gas bubbles in the eye would be one reason, to consider DSO. The other, factors are, desire for rapid visual recovery versus willing to give it the months-long recovery process that it may take. Some of those key factors that would not necessarily apply for my patient population, as well as other panelists have mentioned, ideal for those cases of, central Fuchs, cornea dystrophy, where you have a good peripheral cells to migrate in. And I don't have as much of that in my patient population.
Well,
In the chat, I put a
in
paper
my-
about DSO and
Yeah, go
DMEK. Basically, outcomes were comparable. It just takes a little bit longer for recovery. I don't know if it's as high, Dr.